Our next speaker is going to be Dr. Brad Black, coming to us from Montana. For those of you that don't know Dr. Black, he has been the medical director for many, many years at the CARD Clinic, the Center for Asbestos-Related Disease in Libby. And good morning, Brad. Good to have you with us.
Well, thank you, Arthur. I really appreciate the opportunity to communicate with everybody at this conference. Even if it is from Zoom, I would love to be there. It did not work out this time, but I do miss being there and having that personal contact. But anyway, I will move ahead with this. Today, I just would like to speak with you. First of all, I've been a physician in Libby for since 1977, and then involved in the issues related to asbestos exposure and health outcomes since 2000, and so the last 22 years have been overseeing screening and monitoring of 4,500 people with asbestos disease. We screened over 10,000 since we've been in open. So anyway, I'd like to move ahead. I'm staying on slide 1 in my introduction. I would like to, before I start on the other slides, just to key in on the points of emphasis today. Libby could be talked on for hours, and so today I'm focused on some real issues that relate to understanding detection and recognition of asbestos disease related to the living amphibole exposure. We got to remember, living amphibole is not not asbestos, truly not asbestos. It's non-regulated. However, its hazards remain high in spite of that. And so because of the fact it's non-regulated does not imply that it's not just as dangerous. So, and the other thing to remember is that living amphibole that contaminates the living vermiculite contributes to a significant amount of the legacy asbestos that will continue to create an exposure risk through the long term. The other key issue that I would want to address today, because it pertains to diagnosing the lung disease from the living amphibole exposure, there's a very pattern of pleuropulmonary fibrosis, and it's not well recognized, certainly not around the country, yet exposure is occurring all over the country. So these are the issues that really we need to talk about today. So I wanted to move on to then on slide 2. And I believe this slide shows you a picture of the old mine, the vermiculite mountain, where you can see about 200 feet of this mountain have been removed over the time frame of 1923 to 1990, when the vermiculite mine closed. About 200 feet of the mountain is gone. Now that translates to about 3.5 million tons of ore that were milled and transported throughout the United States. And on slide 3, that transportation went to over 250 processing facilities across the United States. The larger red circles represent the higher tonnage that went to those areas. You'll look in Ohio, one of the largest circles was in Marysville, Ohio, where the Scotts Company was the biggest importer of the living vermiculite in the early years. So anyway, slide 4 does demonstrate the unprocessed vermiculite. You'll see it as a mica-like mineral. It's micaceous, that is, it's a sheet silicate. The crystal is composed of multiple thin plates, and between those plates is the presence of water molecules, and so the processing required a exfoliation process where the unprocessed vermiculite was heated to over 800 degrees centigrade. The steam forces between the individual plates would then separate due to those forces from steam, and expand these particles to 10 times or greater in size from their original form. So slide 5 shows the exfoliated product. I bring it up every time because I have a lot of people that still don't know what it looks like. So I always bring it up to show them what the product looks like. So slide 5 will show a pretty typical example of the particles that then become used for insulation and other applications. It's interesting, this mineral goes from a hard micaceous particle to a spongy type particle that made it much more suitable, of course, for its applications. So slide 6, once again, I think we all know zonalite attic insulation was handy to put in and to add on to insulation in homes, and was poured into homes. Very convenient to install probably in over 30 million homes. It's estimated at least 30 million homes. Can you imagine the impact on the installers? Certainly, we have all the reason to know that many of them probably became ill, and probably a lot of them didn't know why. But in the past, actually, I had a long distance communication from a gentleman in Connecticut who called me when we were in the early 2000s, and he had been to his pulmonologist in his area. And he ended up having asbestos disease, but didn't know really where it came until they explored it. And he realized at an early age, when he was in his probably just out of high school, he insulated homes, probably a total of less than 20 homes, where he would spend maybe 4 hours on each home, maybe a total of 60, 70 hours of exposure within the installation of this insulation. Turned out to be the green bags of zonalite, and that was the origin of his exposure. He sent me his CT study of his chest, and it was just unbelievable what this 60 hours of exposure did to create within his chest. And so it's an example of where this stuff is everywhere. And if we're not looking for it and not thinking about it, it's easy to miss it. His happened to be very more characteristic in the appearance, so that it was more easily recognized. That's not true of so many. So then slide 7, after we looked at the insulation, we looked at it on the slide, but now looking at it with electron microscopy, this insulation, you can see, had bundles of living amphibole fibers on this particular slide. Going to slide 8, this was not news of any kind. Living vermiculite, though it was only less than 1% by weight in the product, the zonalite product, with activity-based sampling, which was done by Deborah Grace in 1978 on an internal study, which that later got revealed in the 1990s in court, showed that their workers that were involved in pouring bags of their zonalite product into containers experienced exposures up to almost 8 fibers per cc. So this was very well known in 1978 and verified by activity-based sampling that this product generates tremendous exposure risk. Even to the point where not just in Libby were there problems, in-product users around the country have developed problems. There's an article published in a few early 2000s, probably 2004, a gentleman that was using vermiculite for packing materials while working in the Air Force. He did about 3 or 4 hours a day over a 10-year period, and he ended up with advanced lung disease. So the awareness was occurring in certain parts of the country, but it just tells you that's probably the tip of the iceberg. So slide 9, I won't repeat all that. It just talks about our experience and the numbers of people that we are involved with. We do have extensive monitoring over 22 years. Many of these people have follow-ups every 1 to 3 year intervals. So we've kept a close tab on the majority of our patient population. So the things that we've learned, obviously, over this time frame is low-level exposure and disease. This is something that not only had we observed in the clinical setting, but also this was also observed in studies in the Marysville, Ohio cohort, which was the largest import of that utilized the Libby vermiculi. Studies from the University of Cincinnati showed very low exposures. Let's go to that next slide. Their health studies at the University of Cincinnati involved the Marysville cohort, which was were employees of the Scott's Company, and they published results of their health studies, and they recognized that with cumulative fiber exposures of 2.21 fiber years, they noted that there was development of pleural fibrosis in this workforce. There was a unique situation here in that the company had very impressive exposure histories. They sampled regularly. They had good estimations of exposure, and so they were able to be much more accurate in terms of recognizing dose and response. And when you look at that, and then you think about the OSHA permissible level at 0.1 fiber per cc, that would generate 4.5 fiber years for a worker of 45 years. So here we are with this Libby amphibole that appears to generate pleural fibrosis at a much lower cumulative fiber exposure. In subsequent follow-up of this Marysville cohort, has demonstrated that it is, and that this is from Jim Lockheed's group there. Dr. Lockheed estimated that the Libby amphibole generates a disease at 3 to 10 times less what we have experienced with other asbestos exposures. So, so slide 12. We're dealing with the key difference here in the Libby amphibole is that it's a progressive pleural fibrosis. In other words, maybe I can describe it best as I left medical school, and when was that? Probably 1974. We were taught that pleural plaques were a marker of exposure, a biomarker of exposure, not disease. But the asbestosis, that is scarring within the parenchymal tissue, the lung tissue itself, is really the disease. And so that was what we were left with, and that was our understanding of those particular pleural changes. But in Libby, this has been what's fooled everybody, and including us, for years. This pleural fibrosis was starting out as a very thin layer and then progressing over time to become thicker, and then became apparent over time. But people did not get traditional plaques. A lot of them didn't. And they would have this thin layer develop in the pleural tissue that was hard to see on X-ray, and a challenge to see on scan in the early stages. So, anyway, so in 2000, I'm sorry, slide 13, we published an article. This really was titled "Not Your Grandfather's Asbestosis." That relates to a quote from Dr. Steve Levan, who came to Libby and looked at multiple cases and was just totally taken back with the different pattern of fibrosis. And that was the comment he made. He was struck by the pattern, the rapid progression, and the severe chest pain that these patients experienced. And the plaques were less frequent, but still associated with progressive disease, as pointed out by Dr. Whitehouse in his publication or in the past. So, so anyway, slide 15. How was Libby amphibole pleural pulmonary disease, I'm sorry, pleural pulmonary fibrosis overlooked for so many years? Clearly, a lack of understanding of exposure risk was a key issue. that pertained to a little bit of, once again, corporate connivery, knowing, looking back and knowing full well how much they knew and how much they hid. And so the medical community did not have any knowledge of ongoing exposure, and had been reassured that we had a safe material that was now being processed. Then the very pattern of fibrosis, the appearance on CT of the chest, is very, the pattern is very challenging, and it's not easy to recognize. And the findings can be very non-specific, and that the pleural fibrosis is certainly through the early to moderate stages of the disease doesn't calcify, so it doesn't stand out as a asbestos-related problem, and so it's easily overlooked. And I want to show you a picture of that in a little bit. Slide 19, this is a disturbing case I wanted to present to you because it is an insulation exposure case. A 52-year-old mother who moved to the Libby area, about 13 miles from Libby, lived in a house for 10 years, an older home owned by the state and that had an office building next to it. They went through 10 years, and then in 2000 realized they were in a home with this insulation in the attic of this older structure. She developed pleuritis in about 2016. Now has had progressive bilateral pleuritis. Her chest X-ray shows a normal. It's on the left, on your left, and the slide should be the normal film, and on the right you'll see bands of scarring and pleural scarring on both sides of the chest. Her prognosis is extremely poor. She did have thoracoscopy, had documented fibrosis of the chest, and the surgeon thought it was most likely asbestos caused. Number 20 slide would be the 75-year-old former Zonalite worker. And I show you this slide mainly because it's the challenges of detection and diagnosis. He had severe problems with chest shortness of breath. Was diagnosed in 1989 by Dr. Whitehouse, the pulmonologist in Spokane, that first recognized what was going on with Libby. There's been no radiologic recognition until 2014, and one of our thoracic radiologists, Dr. Henschke, recognized it. He did have thoracoscopy for lobectomy, and you'll see on slide 21, there is a very thin layering. I can't, if you look toward the right part of that picture of the tissue, there's a very thin layering, a whitish layer of fibrosis over the chest, which is what we were looking at on the CT study before. But I kind of had to run through this. But the point here is this is subtle stuff, but yet very impactful health-wise. And if you don't know what you're looking for, it's easy to miss it. And I think of all the things that we need to do here is, and the last slide is, we need to be out there educating and making people aware of what this looks like and how to detect it. It's extremely important, especially in view of all the legacy asbestos and the fact that it's still not regulated. So I will wrap it up there. Thank you very much.
Brad, your work and laboring in that vineyard of Libby has been remarkable, and the community would not know much about what it knows if it hadn't been for your work and that of Dr. Whitehouse. And it's been a privilege for me to be out there and visit with you and agree with my colleague Steve Levin that this is not your grandfather's asbestosis. So thank you for that.